Yeah, I'm still trying to understand how we get cost control in things like preventative care being free. I have a hard time understanding cost control with if you can have a pre-existing condition, or you can be out of the insurance market. You know, we should talk about the unintended consequences. But if somebody chooses not to be insured, then suddenly gets a something happens to them, and suddenly they can pop in without any penalty, and then when it's done, they can pop back out. And so I have a hard time understanding how that model works from a cost containment. I think the other part, which is going to be very, very difficult to do, is these accountable care organizations. Again, I mentioned those earlier. They sound great in concept, but what you're doing is the only way to get doctors in there is really to say, hey, we're going to pay you more if you come into the system than if you stay out. And so therefore, you're attracting doctors, attracting is not the right word, you're attracting doctors into the ACOs. But I'm not sure you're going to see, and I think you can't separate cost from care and access and quality, and I think they should always be put in together, we can't separate them. But if you have a bunch of doctors who are now forced to operate in a certain way, you guys know doctors, they don't want to be managed, they want to practice care. They don't want to be in a cookie cutter environment. And eventually, a lot of them will be, and you're going to get the kind of doctors that will work in that environment, and you lose all of those that don't. So I'm really concerned about doctors and how many doctors we're going to lose. And I think that's going to be a big driver. So when you have a supply-demand issue, you can't help but think about cost containment. I think it's going to be very tough.
Bart? Well, first of all, cost control depends on who you're addressing. As of January 1st, 2014, you can't pop in and out of the healthcare system. You have to be in there. So we need the young people in there who are the ones who are least likely to have insurance to offset those costs. And if they refuse to do it the first year, it's a $95 fine, then it goes to, I think it's $365, and then it goes to 2.5% of their income. So everyone's going to have a stake in this. If you talk about the hospitals gave up basically $200 billion in the healthcare bill. But they figured they would make that back because you're going to get $30 million coming back in. So they were willing to give up $20 billion per year for 10 years. The cost control. In the last 4 years, the rate of Medicare, and that's sort of standard on how you peg your costs when you're doing an insurance policy, the average cost has been 3.9%, the lowest in our history. The lowest in our history. You can't say that's all because of the Affordable Care Act, but it has a lot to do with it. It has a lot to do with it. So, the docs, they spend so much time now in hospitals with uncompensated care that they were willing to take a hit, if you will. As long as these 32 million people coming in, I'm going to get paid something, and I don't have to chase them forever. For me, in the long run, if I have 99% of people, I'm getting paid for it. 99% of those patients I see, I'm getting paid something. That's better than about 60% that they're seeing right now, and spending a lot of time and effort and money to chase the 40% that's uninsured and will probably never pay.
Great. And hand in hand with cost is the question of improving quality. What's your guys' viewpoint? Does Obamacare have provisions that will have a meaningful impact on quality, improve the quality of care? I saw just yesterday in the New York Times an article highlighting the disparity between what we pay and what we get in terms of quality measures. Bart, what do you think?
Yeah, I think it really will. Big drivers behind moving from a traditional fee-for-service to quality-based outcome was really Mayo Clinic, Harvard Medical, Marshfield Clinic, Cleveland Clinic. They were in there and they were driving us to put in quality-based outcome. Now, we really didn't want to leave it to government regulators. That's why we did the Institute of Medicine, IOM as we call it. They will put forth those standards and what is quality and what it should take for the average patient. And we know that not everyone's an average patient. There will be some difficult cases, and there's extra money in there based upon those quality-based outcomes to take care of those difficult patients. So I think we will see larger quality. Will it happen overnight? The IOMs and the quality-based outcome really doesn't kick in until about 2016, so it's going to take some time. But yeah, I think in the long run it's going to be better. The healthcare bill overall, great emphasis upon prevention, as you said, prevention. Seniors don't have to pay for their flu shot anymore. When you turn 65, you go on Medicare come 2014, you're going to get a physical. They never did that for you before. Why would he do that? We're trying to find the problems early on, to treat it, and try to correct it, as opposed to wait till you're deathly ill, and then we discover it when you're in a nursing home, then it costs us a lot more money. For every dollar you spend now on prevention, you save 10 in the future. And it's just about every program, there's a quality-based outcome, including an up to a 50% reduction on your health insurance premium if you belong to a gym, provided there's a medically certified outcome. Why did you join that health fitness club? What is the medical achievement you're trying to achieve through better, healthy life? You can get your premium reduced by up to 50%. Basically, it's around 25, 35, and it can go as high as 50%. So there's a lot of emphasis on prevention, which should lead to better quality and a better, healthy society.
Ted, what do you think? Better quality, better pay for better performance, so something like free market principles, does that warm the heart of the Illinois policies too?
Does that warm the heart? It would warm it if the private market was doing it, and not a government-controlled healthcare system. I absolutely agree with the intention. I totally agree with the intention. I mean, we would love to see to be able to hold everybody accountable. But I think what's really interesting, those of you who've got kids and have looked at education or studied education or read about it, it's another government-run system, and they all the time try to figure out how to reward or try to figure out what works in education. And what we find is it's really, really hard to define what are the factors that most impact success of a kid. It's really hard. It doesn't matter how many regressions you do and all that. It's really hard to do. And so it's really hard to compensate based on something like improved quality. And I think it's just equally as hard to do in healthcare. Now that doesn't mean we don't try to do it. The question is who's deciding whether that quality is good enough or if it's better. And is it going to be a committee? Is it going to be a list? This is okay, do a check off. Here's the patient, and there's the doctor. And how am I going to figure out if that patient's really better or not? These are really complex things, and I think you guys know that. I don't disagree with the intent, but what I don't think it should be done is through government. And so that's why we're very cautious about outcomes. And let me give you the Medicaid story one more time on Illinois. Yes, we added tons of people. This was good, right? If you look at the graph of how many people were added on the Medicaid rules in Illinois, it looks fantastic if you're pro adding more people on the Medicaid. But the federal courts got so upset with some of the results of patients that they ordered a study. And they looked at the poorest of the poor, particularly kids. And kids with juvenile diabetes, it takes them up to 3 months to see a doctor if they can get it at all. And that compares, and they did this study across quite a few sicknesses, disastrous results. And that's because they can't get the access. People don't want to see them. So I think we run a very dangerous case of putting more and more people onto the government-based system. And so, I think that all the unintended consequences that come out of this will really hurt quality.
Ted, you liken the new healthcare system as being more like a utility, and whether you like what that does to the utility industry or for healthcare, matter of taste. But one thing you can say about those highly regulated industries is they're very predictable. The rules are well known, and at least you don't have episodic industry participants entering or leaving the industry. More or less, unless you're doing kind of the lights come on and you turn on the switch. Okay. Is this bringing more predictability and a more stable business environment to healthcare?
Well, so I said if things work perfectly according to what some people believe that the government support of the system can do, then you would hope that it looks like a utility. But we're big believers in the individual spirit, and we don't think that those Medicaid patients that can't get access. We don't think that's fair. Unfortunately, they can't do much about it, so they're kind of stuck. But we do believe that those people, middle-class people, higher-income people, will buck the system. And they're not going to accept lower quality care at a higher cost. So if you're a believer that the system won't work, there's going to be a two-tier system. And you already see it. I was talking to a colleague yesterday. She's a consultant. and she helped a gentleman who was in Louisiana fly to Las Vegas to get, I forget what kind of surgery it was, but instead of costing $30,000, it cost $6,000, or something like that. There's a huge difference. You know, why does medical tourism? Why is that popping up? Why should Canadians be able to get a price list that is exactly how much something costs and do it for very much cheaper than somebody else who actually lives in Louisiana, for example? People are going to be bucking the system right and left, and the question is going to be, from an M&A perspective, what are those businesses that kind of pop up outside of the system to start to attract a lot of business?
Well, I think what I hear you saying is there's going to be some niche businesses coming out to take the people to serve their needs that are looking for healthcare outside what the government mandated approaches are going to be.
Right, and just to finish, I'm sorry, Bart made a point where individuals are supposed to be insured, right? That's the mandate. But the penalty is a lot less than the actual premium cost. And given community ratings where I, as a young person, if I were a young person, I would pay significantly higher premiums than if I were insured under the pre-Obamacare period. I think the premium would go before Obamacare has gone up 3 or 4-fold for a young person. If the fine is a lot less, I'm not going to be insured. And I think that's the kind of stuff, and we talk about employers, Brian, employers who have less than 50 employees, they're going to play all the games they can to try to get people on the exchange. It's all these consequences are going to lead to people bucking the system. Yes?
Okay, so, escape valves, healthcare refugees, game playing, Bart, what do you think? Is that what the future holds for everyone?
No, Ted keeps referring to it as a government-run system. We may set the floor and say, here's the floor, but you have to have your basic minimum plan you're offering. But any insurance company can get in. Remember, when we passed the bill in the House, we had a public option to compete with insurance. That was rejected. We went to the state Massachusetts plan, if you will. And who really decides which plan I'm going on? It's back to you, the consumer. That's a complete switch from where it was. When I was in Michigan State Police, I had one choice wherever the Michigan State Police policy was. And that's what I was stuck with. Now I at least can go and have a choice. And even if my employer offers insurance, if I don't like it, I can go back on that exchange. And for young people, remember, it's 2.5% of their gross income. So if I'm making $40,000, that's almost what? I'm not a math major, but about $5,000 a year. If I'm single, 25 years old, I probably could afford to buy something like that. And that goes up with the rate of inflation every year thereafter. So it's not going to be people will be looking at it and say, well, I'll go naked with insurance because I can't afford it. We've actually tried to factor that in. So, I mean, the best model we got, you go back, and I see the Massachusetts plan, take a look at it. Last stats I saw, maybe a couple months ago, was still 67% of the doctors think that the Massachusetts plan was working and was pretty good for them. And about 2/3 of the same percentage of the people in Massachusetts were pretty happy with their plan. And they're pretty happy with it. So, I mean, for some people paid more, some people paid less. Do I think that there will be a tiered system maybe? Yeah, I think you're going to see some of these doctor groups saying, I know you got your insurance premium, but I'll tell you what, I'll be available, our group will be available 24 hours a day, 365 days a year. If you pay us $400 a quarter or $1,600 a year over and above your insurance. Well, there's a number of those plans in Washington, D.C., there's a number of plans popping up, concierge service, as they call it, throughout this country. So I do see, so if I need to fly to Las Vegas or something, well, a kid in south side Chicago can't do that, but maybe a CEO kid or upper management people. So I do see a tiered system developing in the free enterprise system. And getting back to the whole thing, Ted mentioned a little bit about access. You get so many more people on Medicaid, but do they have access to health care? That's the real issue. I can have all the insurance cards I want, but if I don't have access to it and can't access it, we're in trouble. In the bill, it was $11 billion just for federally funded health clinics. And in my congressional district, we go 2-3 counties before you ever saw a hospital. But the federally funded clinics took everybody. First it was a Blue Cross Blue Shield card, a Medicaid card, to the uninsured, and they have a sliding scale. And it works, and they provide quality health care. And that's why the incentive in the bill For family practice, general practice GPs, there's an extra 10% reimbursement rate over and above the specialists, because we're a country of specialists. We don't have very many GPs or general practitioners anymore.
If I could just make one point. I think one clarification has to be that the word exchange, this market exchange is where you're going to be able to buy insurance. It's a misnomer because it's not a free market exchange. There's going to be lots of mandates from the federal government as to what that insurance product must look like. And it's going to include a lot of things that I or you may not want, and that's all you can get. And it's the federal government, it's not the states, it's the federal government who decides every bit of that. They say the states will have input, but in the end, it's all has to be approved by the federal government. So it's not really a free market. If it was a free market, and this is a big issue as well that we haven't discussed, is what happens to high-deductible plans and HSAs. If you really wanted to liberate the market more, you'd have people who have skin in the game for what they're paying. And I'll tell my personal story. I worked overseas for about 16 years, had a fantastic plan with Citigroup, left in early 2007. Don't think that I was smart. It's not the crisis, it was just luck. But I had this great package, 4 kids. We used the heck out of the healthcare system, and I didn't care at all about what I spent. But I decided to change my life. I went got a master's degree at U of C, put a backpack on, and I started to pay for my own insurance for the first time in my life. And so I got a really high deductible, and I was going to try to manage my costs. I was a student. And it's phenomenal. I really played the game. I would walk in every time I'd walk into the doctor's office and say, how much is this going to cost? I'd get blank stares. Blank stares. And I wanted to manage my costs. That was my goal. I wasn't trying to play a game. And then my daughter had surgery. I could not figure out what was going on. But I did find out that if I talked to the right person, they could change the codes and drop the cost. So it was phenomenal. And so that kind of experience tells me that that's not a market system. That's some other kind of surreal system. So we've got to move to something that makes much more sense.
So maybe here as we get close to the end, try to wrap up. Winners, losers. Who came out well? Who didn't come out so well? Bart, you had a front row seat as legislation was working its way through Congress. What are your observations?
Because what Ted said and the other panel said, transparency was only applied to really the hospitals. So I think the American Medical Association came out the best because there's no transparency. So if you do want to know what it costs, if you want to be a smart consumer, it's still going to be very, very difficult. It'll eventually dribble all. But the First Amendment offered by Joe Bart of Texas was transparency. And I'm a senior member on the Energy and Commerce Committee, and the 3 Democrats before me all voted no. Of course, I voted yes. And the chairman Henry Waxman came over and strangled me, but I'm a little bigger than Henry, so he didn't bother. But he was mad. It was like, look, we're all supposed to hang together in this. And I said, well, look, are we interested in doing healthcare, or are we interested in doing politics? And my biggest disappointment, there are some parts of that bill that's political and not healthcare related.
Well, I think winners and losers, I just sticking with my own theme, I think anything that's concierge outside the system, I think that's a big success. And again, I'm not an expert in your world, but big data and consulting, absolutely. There's going to be a lot of work for that. IT.
Health and information technology.
I really like this whole concept of, if we really want to lower cost, we've got to deregulate. Let nurses and other kinds of practitioners do the work that's not so expensive. So walk-in clinics and all those big, I think anything that's really bringing down cost is a big driver. Get excited about that. Telehealth, those areas. I know those aren't the big ones, but over time, they may be the ones that kind of crop up as you get consolidation. And once you reach a certain amount of consolidation in hospitals and insurance, then you have to start looking elsewhere.
And then finally, the future, for our last piece of the puzzle. To the extent you can project forward 4 or 5 years, a new administration, regardless of Democrat or Republican, what's the legislative issues that Congress will be grappling with at that time? What's the next version of Obamacare or amendments therefore?
I think the next one will be expansion of the exchanges. You know, you only got about half the states who are really, only 7 really doing their own state exchanges, and you got this hybrid federal state. So I think that's going to switch. I think the states will go back more to the exchanges and try and get more approval, put more flexibility within their state plans. So that's where I see the next change. If the next president is Republican and the Congress is Republican, I don't think in 2016 would be 2017 before they had a vote, they would ever overturn it. I think once people have an insurance card and can get insurance and have access to health care, I don't think it's going to be repealed. And gloom and doom, we saw the same gloom and doom we heard after Medicare. Now I'll try to take away Medicare and we'll have a riot on your hands.
I think you're absolutely right. It's a political question. The trend now is to continue on. But if Republicans do get more control, then I think you'll see big challenges. Regardless of if the Republicans don't, I think you'll still see more moves to get more skin in the game. Maybe it's very hard to do, but if you don't get that, if you don't get something like a high deductible plan as part of the landscape, then it makes it very hard to ever do much. If it becomes like a utility, I mean that in a positive sense, there's not a whole lot to do, but I'm not sure that the American people are going to accept the level of quality that comes from that. And I'm not sure that people are going to accept the lack of access that poor people are going to have. So I see this as a continuous challenge. And you know, it's from my perspective, from a liberty-based perspective. If we can keep pushing this kind of plan and have a top-down approach that despite whatever private sector engagement it is going to be very much determined by government control. If we can do it in this, why not do it in other industries? And it's a real danger, and we, of course, would like to see the opposite occur.
Well, Bart, Ted, I want to thank you. Even though you came from very, very different perspectives and backgrounds,